Good morning, everyone. Good morning, everyone.
Good morning.
Good morning, sir.
Good morning.
How's it in Kuno? I believe a lot of rain and shutdown, electricity shutdown. Is okay now? Dharani, Kuno.
Yes, sir. No, it's okay, sir.
I believe there was an electricity shutdown on Saturday.
That was only on Saturday. Yes, sir.
Is it happening often?
No, sir. Monthly once.
Monthly once?
Yes, sir. Mostly, yes, sir.
On the day when one of the consultants come there?
No, sir. This was on the first Saturday. Usually they conduct it on second Saturday, sir. Not on the first Saturday. This time it was on first Saturday, sir.
You tell Michael to let us know early and make sure it doesn't coincide with our doctor's visit.
Sure, sir. Sure.
You follow me?
Yes, sir. Yes, sir. Sure, sir. I'll let him know.
Yeah. He was saying that even the X-rays could not be done.
Yes, sir. It was from 9 to 5:30, sir. Yes.
Oh, that's it.
Yes, sir.
You also couldn't filter a lot of cases, eh?
Sorry, sir.
You couldn't filter a lot of cases.
Sir, if the X-ray is necessary, we will send them to Nankam, sir. There they will be having a generator, sir. So they have the facilities to take X-ray. So if you want X-rays, we will be sending him, sir. Yeah. Since there was shutdown, people were not ready to come to the OP, sir.
I think on Saturday or yesterday, I'm not sure. One guy came from Kuno directly. It is referred by Rajiv. Rajiv is a football player, one of our old patients. He's a coach for Lakshadweep team with ACL. I don't know. I'm not sure if he came to Kuno.
Yes.
Have you been anywhere for any talks, met anybody? And what's happening to the IMA? Anything? Any news?
Sir, Michael met one IMA, like a small meeting, I think so. He went, sir. Like, I'm not sure where. He went one day to meet some IMA officials, sir. To Ooty one. Yeah.
Okay, I think it's time we start a meeting. Okay.
Yes, sir. Can I start, sir?
Yeah, please.
Good morning, everyone. Am I audible, sir?
Yeah, Rohit, go ahead.
Oh, all right. So today's talk is on knee positioning and knee draping. So before we talk about knee positioning, let's have a look at the components that are required for a normal knee positioning. You need equipments like the leg holder, the tourniquet, the side post, footrest, and the lithotomy stirrup. Leg holder is nothing but it's just a device that keeps your leg firmly in position. It also aids in giving varus and valgus stresses and stabilize the lower limb. The tourniquet is nothing but the pneumatic one that we use. It should be applied in a proper systematic manner. The thigh should be first cleaned properly with a septic solution. A soft roll should be applied, over which tourniquet should be applied, and then it should be properly tightened. After that, it should be checked. Before applying, it should be checked whether there are no leaks, air leaks, and there are no cuts or anything like that. The tourniquet should be applied between the proximal and the middle third of the thigh. And it should be taken into mind that when we are scrubbing the leg or painting the leg, the betadine or the scrubbing solution should not percolate between the thigh and the tourniquet. Otherwise, it will cause burns. Side post is a inexpensive device which is used majorly for supine positions. It can use to prevent the leg from going off the table. It again aids in it aids in giving varus and valgus forces, and it's attached firmly to the OT table. A footrest is device that is used to put the knee in flexion and to attain and to keep it stable while performing supine position arthroscopies. That keeps foot stable and firm, and it directly attaches to the OT table again. The lithotomy stirrup is another device which is used on the contralateral side of the leg. It helps to stabilize the leg, and it moves the contralateral leg away from the sterile field. So what are the ideal knee positioning requirements? So it should be accessible for all joint compartments. That is, the knee should be positioned in such a way that all the medial compartment, the lateral compartment, the cutters, the recesses, everything should be easily accessible through that position. It should be convenient. No lack of, there are infrastructures in places where there are inadequate staff, or minimum staff should be utilized for all this. So there shouldn't be people assigned to just hold a leg, or assigned for one particular thing. So all this convenience should also be taken into factor. Then in case when you want to convert arthroscopic surgeries into open surgeries, it should be easily be doable. It shouldn't be cumbersome as to change the position, get away with the sterility. Sterility shouldn't be hampered, all that. Then it should use simple positioning devices. Like I mentioned, the side post is a very simple positioning device that can be used. It should be tourniquet free access should be there. It should provide unrestricted access to perform surgery when it's uninflated, and inflated when the need arises. So basically, when you look at it, there are two major positions. Then is a straight leg position, that's the supine, and the knee flexed position. The straight leg position, it's simple, it's fast and secure. Like I mentioned, the prerequisites, the straight leg position takes into account all these prerequisites. A side post is mounted on the operating table on the lateral side of the thigh. The side post is positioned about hands width proximal to the base of the patella. Difficulty to access posterior portals with this type of position, and the surgeon can sit. That is a major advantage during the entire arthroscopy. Flex knee position. This provides the medial fulcrum so that the varus and valgus can be given. In this position, better varus and valgus stresses can be given. Requires special instruments like the leg holder, the lithotomy stirrup, and the surgeon has to stand throughout the procedure except for graft harvesting or so. Another disadvantage is maintaining adequate sterility, because the leg is hanging. Sometimes it can happen so that the drapes can touch the floor, the leg can touch unsterile area, and then cause a major issue. Another new article that I came across was this prone knee position article. So basically, Mahmoud Kayap did a review study on prone position knee arthroscopy for isolated retropatellar cartilage defects with a gel type of autologous chondrocyte implant. He studied 5 patients, and he showed that the chondrocyte implantation is a promising technique to address isolated retropatellar cartilage defects. Now, in this technique, the patient was completely made prone, and superior lateral portals were made and anterolateral portals were made. This position was ideal for looking and tackling into the retropatellar chondrocyte defects only. They did not access the posterior compartment with this position. And this position states that there's a advantage of preventing arthrotomy, the incision smaller, and complications are lesser. But most studies are warranted for prone knee position arthroscopy. So, as it's not routinely done, as surgeons and anesthesia and OT tech is not trained accordingly. Coming to knee draping. Knee draping. Since arthroscopy is performed in a fluid distended joint, the entire surgical field must be covered with waterproof and sterile drapes. Water-resistant disposable material is available for this purpose. So the surgical draping for knee arthroscopy is performed in layers with an assistant holding the leg. First layer is applied by affixing a sticky drape. This is after scrubbing and painting. Sticky drape first with the tails going up, placed just distal to the plastic drapes applied before preparing the leg. Next, a second sticky drape may be applied with the tails facing down. This is on the top angle so that the drape covers the ipsilateral arm board. Third, finally, an arthroscopy drape is positioned over the foot. This generally has a hole or a diaphragm that seals the arthroscopy fluid and prevents it from leaking up under the tourniquet or off the arthroscopic field. As an option, an impermeable stockinette may be placed over the foot to seal it off from the arthroscopic field. The stockinette may be held in position with a Coban wrap. This leg is then lowered to the bed. At this point, the surgeon or the assistant will elevate. Now, to help you all understand better, I'm demonstrating everything in this small video.
The patient is positioned with their heels at the end of the table. We then move their pelvis, the ipsilateral side, the side that you're doing surgery, right to the edge of the bed, which gives us the best leverage for positioning the leg against the leg holder or post. After the patient is positioned, a safety belt is placed around their waist. Next, we will place the tourniquet. With an assistant holding the leg, we first wrap cast padding once or twice around the thigh, trying to avoid wrinkles. Perfect. Next, we will place the tourniquet. The tourniquet is held in position with Velcro, and it's important to remember to put this high enough that after the patient is prepped and draped, it will be high enough or proximal on the thigh that there is room to work. And generally, we'll set the pressure on 350 millimeter mercury for a normal adult male or female. Finally, a plastic drape is affixed to the patient's thigh so that the preparation solution does not drip up and under the tourniquet. After the tourniquet is placed, the leg is lowered into the circumferential leg holder, which we will demonstrate first. The leg holder is squeezed closed, the straps are placed, and the foot of the bed is lowered. A surgical assistant holding the leg may then push the leg laterally or into valgus to expose the medial compartment, and medially or into varus to expose the lateral compartment. If a surgeon is operating without an assistant, the surgeon may push the leg on his hip and use his own hip to position the leg laterally or valgus for the medial compartment and medially or varus on his opposite hip for the lateral compartment. Lateral post is locked into position. The post allows the surgeon or his assistant to grasp the foot and push it into valgus or push it laterally to expose the medial compartment. If a surgeon is working without an assistant, he can place the leg on his hip and use his hip to push the leg laterally or into valgus while using his hands to operate the camera and instruments in the medial compartment. After medial compartment arthroscopy is completed, the surgeon bends the knee off the end of the table. The post may be lowered. This allows arthroscopy of the intercondylar notch. The surgeon takes the ankle and rests it across the contralateral leg with the knee bent to 90 degrees and sometimes applies pressure on the knee. Pushing the knee to the floor allows the hip to externally rotate, which imparts a varus force, allowing for lateral compartment opening and arthroscopy. Now we are going to demonstrate draping for knee arthroscopy, which is performed in layers. With an assistant holding the leg, the first layer is applied by affixing a sticky drape, first with the tails going up. Next, a second sticky drape may be applied, this time with the tails facing down. Finally, an arthroscopy drape is positioned over the foot. These generally have a hole or diaphragm which seals the arthroscopic fluid and prevents it from leaking up under the tourniquet or off of the arthroscopic field. As an option, an impermeable stockinette may be placed over the foot to seal it off from the arthroscopic field. The stockinette may be held in position with a Coban tape, which sticks to itself and holds it in place.
Coming to portals now. The portals, they're the fundamentals of arthroscopic surgery. So how do you make an adequate, or what is the technique of creating an adequate portal? The position of the knee should be flexed around 70 degrees. Then identify all anatomical structures. First, the patellar apex, the patellar tendon, the lateral medial condyles have to be apex. The medial and the lateral triangles have to be apex. After that, then you go in, you identify where you want to take the portal. The optimum site has to be identified. After you identify the site, you infiltrate with the local anesthetic. Now, the local anesthetic provides an advantage that it prevents post-operative pain. So, and along with that, since it's also got adrenaline in it, you can go in for a without tourniquet initial arthroscopy. Then a skin incision is taken, which is transverse around 5 millimeters. This transverse incision helps in moving lateral to medial, the scope. Then the sheath is inserted with an armed and blunt trocar that is introduced. The obturator should be securely placed at this stage to avoid any chondral damage. After that, the joint is extended and then you enter the joint. So these are the basic few portals that normally are taken. The left is the medial side, the right is the lateral side of the left knee. This is the left knee. The superior medial portal, the posterior medial, accessory anteromedial, anterolateral, superolateral, and the posterior lateral portals. The superior meniscus portal is just placed proximal to the meniscus rib, and care is taken not to cut the meniscus. The high medial portal is placed at the level of the patellar apex at the patellar tendon, provides access to the lateral meniscus. The suprapatellar portal is placed slightly proximal to the superior border of the patella. Now, the suprapatellar can be medial or lateral. Medial will have to take care of damaging the VMO, and laterally, you have to take care of the vastus. In 1976, Gilchrist described a portal that was through the patellar tendon, 1 centimeter below. That's called as the Gilchrist or the central portal. Lateral portal, the normal high anterolateral portal is the visualizing portal, and the other portals are the instrumentation portal. Then you have the high posterior medial portal, the standard and the low posterior medial portal, and the posterior lateral portal. So this is just a brief description.
Today we're working on a left knee. Now we're going to review the surface anatomy. We have marked the kneecap, the tibia tubercle, in dotted lines, the patella tendon, the medial and lateral tibial joint line. And typically, the lateral joint line is a little higher than the medial, the head of the fibula, and finally, our 3 arthroscopic portals: anterior lateral, anterior medial, and superior medial. Advanced arthroscopists may only use two portals. I will not use the superior medial portal today, but it is excellent for allowing fluid outflow. The anterior lateral portal is placed 1 centimeter above the joint line and just next to the patellar tendon. You can also feel a soft spot. The anterior medial portal is placed 1 centimeter above the joint line and 1 centimeter medial to the patellar tendon. You can also feel a soft spot. Typically, we inject our portals with local anesthesia and then use a 15 or an 11 bladed knife with the blade facing away from the patella tendon to make a 4 or 5 millimeter portal, cutting the skin, then the capsule, but taking care not to damage the ligaments or cartilage and taking care to stay above the meniscus. We then take the cannula with the blunt obturator. I hold it like this so that my finger will prevent me from plunging. I angle to parallel the tibial plateau between the condyles and you push into the intercondylar notch. You may want to go in and out a few times to make sure it's loose. Then you pull back just enough that you're outside of the condyles. You straighten the knee and slip under the patella. After slipping under the patella and with the knee in full extension, we remove the obturator and put the arthroscopic camera in the cannula. We turn on our water and wait as the knee fills with fluid. I'm going to now prepare the anterior medial portal. In order to get the exact portal placement, we're going to use visualization with the camera and a spinal needle. Again, I'll hold it toward the tip so I don't plunge, and then trying not to damage the cartilage, I will come in with the needle just above the meniscus. Any lower would cut it. But then I have to be sure I can get to the posterior horn of the medial meniscus. Because as you can imagine, if we come in too high or too vertical an angle, the femur will prevent us from getting all the way to the back. This seems like a perfect portal location. So we'll pull the needle out, take our knife, and again, first cut the skin, approximately 5 millimeters, and then deeper, holding my hand against the skin for control, I'll cut the capsule. And you see when you cut the joint capsule, you know you're there because the fluid starts coming out. This is our working or instrumentation portal. I like to take a hemostat, and again, I'll hold it like this so I don't plunge, put it into the portal, and spread a few times. Watch your eyes, this can squirt. To have a nice loose portal so that you can come in and out with ease as you're doing work in different areas of the knee.
So take-home message, pre-operative planning is extremely crucial in planning positioning of the portals. So before getting into surgery, we should exactly know what we're dealing with, whether it's a ramp lesion, whether it's the posterior meniscus, whether it's any other part of the meniscus, any other ligament, collaterals. So pre-operative planning is most important. Know your OT setup. Thus, you can modify as per the case and as per your setting. Be cautious when making portals so as to not injure cartilage or meniscus. And portal placement and sterility are key to a hassle-free surgery and outcome. Thank you.
Thank you, Rohit. You covered all the important things. A few points to add is positioning. Most of when you go out and do scopy, here you see technicians and assistants usually position them because they are trained. But when you go out to another multi-speciality hospital or when you start practice by your own, you need to know how to position the patient. It's key. If your positioning is not right, your entire surgery will become much more difficult. So fellows, do be there and try to position the patient yourself. So I do notice many times, as it was pointed out, the foot is not at the edge of the table. Sometimes we need to adjust them and do position the patient being aware of what surgery you are going to do. The position varies depending on the surgery. Just go through the surgical steps mentally before you go in, so that you think over the steps, and then sometimes you need a C-arm radiography intro-op. So then you need to see whether the part which you want to cover, suppose you need a full length in an HTO, you need to make sure your hips are visible in the C-arm. It's always better to check before you start draping the C-arm whether the hips are covered with the C-arm. Because the hip area, you need to bring the patient further down. So the foot might be hanging out. So being aware whether C-arm is required, whether all parts are being covered by the C-arm is also very important. And radiolucent table mostly would be available in an orthopedic setup. Regarding the positioning of, you did mention most of the things, even bronchoscopy. I think bronchoscopy was first introduced by Renaud Siebold from Germany. We do have few cases of that, which is useful in patellar ACI, as you had mentioned. Apart from that, recent advances. Rohit, are you aware of any recent advances in positioning instruments?
So
We have the shoulder positioning instrument, right?
Sorry, sir, I didn't get that.
For the shoulder, we have a
Yeah,
spider.
yes, sir, we have something like that, spider, sir.
So can that be used in the knee?
So the shoulder joint is more mobile, and the knee joint.
Yeah, it has a knee attachment where you can use it in knee.
All right,
So
sir.
we did have a trial of that. There are a lot of difficulties of using it. It is not possible to get the patient to a figure of four position for visualizing the lateral meniscus with that instrument. So they tried to push that. A knee with a knee. What is it? A knee specific attachment added to it. But we tried it. It didn't work well. It is more cumbersome. So if at all somebody comes and pushes it, do try these things before venturing into newer advances.
Yes, sir.
And regarding draping, you did mention it, and covering the foot with the water resistant, waterproof covering is what Sir has been rigorously following, which helps us reduce the infection because the foot area is going to get soaked. And when you do that clean film, which we do, you need to cover it till the calf, little firmly. Why is that done?
So to prevent the posterior a collection into the calf, sir, the fluid.
Correct. Specifically in posterior surgeries or PCL surgeries, where that compression will help us reduce the compartment pressure. When you release it, it will spread it out, and it doesn't help. It helps in reducing the posterior compartment pressure reduction. That's one thing. And draping, there are specific drapes for knee arthroscopy where fluid is collected and drained out so that it doesn't flow out. Are you aware of that?
So I've seen a few videos on YouTube, sir, but I couldn't get proper literature for that, sir.
Yeah, they are useful because spillage in the theater setup is reduced. But no great advantage. But if you want the spillage onto your foot pedals reduced, then you can use them. But what you would have seen, our foot pedals are covered with plastic covers so that their longevity is not reduced by soaking them in water. Saline, sorry. And last point regarding your portals, you showed horizontal portals. Which you think is better, horizontal or vertical?
So the thing is, I feel for the visualizing portal, as the anterolateral portal, the vertical portal is better. Whereas for the working portal, I feel the horizontal portal is better. So.
Okay. Both has its advantage and disadvantage. We don't use them for a few reasons because of when you do the anterolateral portal, when you do a horizontal nick, because it's a learning center, we tend to cut the patellar tendon if it goes close to the tendon. And if at all, if it's too high or too low, if it's a vertical, you can extend it so that the number of incisions remain the same. So patient do not complain. If it's too high, we can extend the incision and come down. Same way, medially, we do have incidents of, as mentioned in the video, you have incidents of cutting the meniscus. Lateral as well as medial, but there are no reports. Santosh, ex-fellow has to report this. He's working on it. Santosh also needs to report on this. He's working on it.
Yes, sir.
Nothing much to add. It was a good talk. Sir, your points.
Yeah. Rohit, these kind of talks, instead of picking up from the net, you could have taken series of photographs of our own draping and explained it. And most of what is showed is leg holder, which we don't use now. And we started with only leg holder, then slowly switched to just supine. Leg holder also has its advantages. Still, we use it for PCL. For a beginner, it's much easier, especially when you don't have many assistants. The leg holder itself behaves like an assistant. Got its own advantages. And another thing I would like to emphasize, what Dr. Santosh has already said, you have to clean and scrub the toes in the ward. And when you paint, you must paint the toes completely, foot completely. Otherwise, when you lift the leg up, sometimes some contaminated water gets back to the field of surgery, and I had infection due to that. That's the reason why we completely seal it. So every point is important. You got to make sure there's no chance for any infection. Thank you.
Thank you, sir.
Good morning, sir. My topic for today is knee instruments and implants. Arthroscopic surgeries is characterized by use of minimal access sites, since it is essential to preserve this advantage. Specially designed instruments had to be developed to perform the largest possible range of arthroscopic operation. Various criteria are used in judging the quality and performance of the surgical instruments. Based on the function, the instrument should function according to as it is meant to be, the size, stability, safety aspects, and the procurement cost. The probe is become known over the years as the extension of the arthroscopist's finger. It is essential for palpating the intra-articular structures, planning the approach to a surgical procedure. Most are right-angled. Marking is mainly at the 5 mm. The tip size is fixed to 2 mm. This is used to measure the length of the structures inside the joint. It is always, we should use the elbow of the probe for the palpation. Magnification occurs with the probe. The closer it is, the higher the magnification. The probe mainly can be used to assess the strength of the ACL ligament, or else the probe is used to palpate the meniscus. The probe can be used to see the undersurface of the meniscus if there is an undersurface tear. Mirror, though it is not commonly used, it is a simple way to expand the visual field to introduce a small round mirror into the joint. It can significantly increase the extent of the visual field. By using mirror, the arthroscopist can inspect a number of articular structures that previously visible only with great difficulty. The anterior horn of lateral meniscus, after excising a flap, the anterior horn is hardly visible, but with the help of a mirror, it can be seen. Whereas in the evaluation of PCL, in patients with ruptured PCL ligament, the ligament can be inspected with a mirror inserted through the posteromedial portal. Mechanical instruments. Mechanical instruments for the knee arthroscopy has relatively uniform design consisting of jaws, shaft, and handle. The shaft may be straight or curved. The jaws may be straight or angled in relation to the shaft. Straight instrument. Most commonly, these instruments are used to cut the posterior aspects of some in meniscal tear. The angled instrument, it can be the angle can be up, down, right, or left, which can be used in the meniscal resection. And curved instruments, these are not commonly used because it needs a bigger area and it can cause the chondral damage inside the joint. The basket forceps. As the workhorse of an arthroscopic surgeries, the basket forceps, known also as punch or cutting forceps, is most commonly used mechanical instrument. Various types and degrees of angulation are available, but straight and up angle instruments are most often used. Open base where the cut tissue is dropped, which can be removed later. No need to remove from the joint with each bite. Indication, it is mainly used in division of tissue bridges, for example, in bucket handle tears, removal of degenerative meniscal tissues, division of scarred tissue bands, detachment of undermined cartilage flaps, piecemeal removal of the soft loose bodies. Disadvantages, piecemeal removal after using the basket forceps. If the large chunks are excised, then it is advised to use a shaver and remove that chunk, as it may cause future irritation. Second is the retained tissue fragments. Third is the poor control of resection depth. The special type of basket forceps is suction punch. It is connected to the vacuum suction and virtually eliminates the intra-articular retention of the tissue fragments by removing from the joint as soon as they excise. So there is no need of taking out the forceps and using shaver if this punch is used. Retrograde basket forceps. In bucket handle tears, the anterior attachment of the fragment may be not fully removed with basket forceps through the medial portal. This can be solved by retrograde of back-biting forceps. The grasping forceps. Indication, it is mainly used in meniscal fragments to remove the loose bodies, cartilage, flaps, osteophytes, retrieving a synovial biopsy, or grasping the sutures for arthroscopic repair and reconstruction. The first image, we can see the removal of a loose body with the help of the grasping forceps, but the edges are not serrated. So the main problem we face with that is it can lose while removing from the small portal. So it is always advised to use serrated edges. The scissors. Arthroscopic scissors are 3 to 4 mm in diameter and are available in both small and large sizes. The jaws of the scissor may be straight or hooked. The hooked scissors are preferred because the configuration of the jaws tend to hook the tissue and pull between the cutting edges of the scissors. It was used in earlier days, not used now because of high rate of implant breakage within the joint, and it can cause chondral damage. Knives, widely used in early days of arthroscopic surgeries. Most knives have to be used on a cutting surface. The retrograde knives and smiley knife are still in use today, but it can cause chondral damage and meniscal tears, so it is not used. Chisel, difficult to insert into the joint and may damage the articular cartilage. Rounded edges will protect the cartilage and will be easier to pass through the portal. Chisel with sharp edges tend to hang up or in the portal during insertion. A curved chisel is very useful in notch plasty. Files and rasp. Following the removal of osteophytes or after notchplasty, the resection site should be smoothened. Files can be straight or angled head. Right angle rasps are used to freshen meniscal tear prior to surgical repair. Here is a small video which we can see the meniscal tear is being edges being freshened with the help of a rasp. Curates, they are used to smoothen and round off bone tunnels, can also be used to debride bone surface covered with soft tissue or scar tissue. Unstable cartilage fragments can be removed with fine curate without violating adjacent cartilage areas that are still intact. Here is a short video in which the curate is used to make a the root repair, and whereas the ring curate is used so that the only the articular cartilage is being removed, not the bone. Irrigation cannulas, they have beveled opening at the end of the barrel, and tip configuration permits easy insertion through the portal. The extra-articular opening is placed on the side of the handle. This is used so that the debris and the blood can be outflow with this cannulas. These are the common instruments which we use. First is the trocar and the blunt obturator sheath. Second is the fluid outlet. First is the suture retriever, and second is the diamond curate. And first we can see the rotatory basket forceps, which we use in the which can be used in the resection of the anterior horn of the meniscus, the right and left side. This is the meniscal grabber, and the third is the knot pusher. These are the instruments which are used in the all inside meniscal repair. First image is of left side, and second image is of the right side. Anterior third, middle third, and posterior third. They are various depends upon the to accumulate the condyles of the femur. Here's a short video in which the all inside or meniscal repair is being done with the needle and the suture. And these are the root repair jigs, which is different for each side, right and left, to accommodate the curve. And these are the scorpion, which contains the scorpion needle and the suture retriever. And this is the first pass mini Smith and Nephew. The main difference between these two is one can accommodate 0 fiber wire, while one had 2 fiber wire. And these are the suture passer, in which in restricted joint space where the first pass or the scorpion cannot be opened, this can be used to take bite in the suture, in the meniscus. In this, we can see how the scorpion is used to take a bite in the meniscus during the meniscal root repair. And we make sure that the needle does not pierce the condyle, so it is tilted, and so that it doesn't damage the condyle. These are the meniscal repair, all inside meniscal repair kit. This first one is of the Stryker company, and second is of the Smith and Nephew. We can adjust the depth according to which we need. And the third image consists of the all inside meniscal cutting devices. And the third image, we can see the bender to accommodate the meniscal bend. Here, the handle is kept, all inside device is pierced. and we use the cutter to cut as well as to push the knot. These are the jigs used in the PCL. First is the tibial and second is the femoral jig. The second is the popliteal protector. The third is rasp and scoop, which are used in the PCL surgeries. And first is the dilator or the cannula, which is used during the PCL surgeries to reduce the fluid outflow. And the second image is of the tendon harvester. There are two types, open and closed, and the sizes depends upon the width of the tendon. There's one article which states that arthroscopic surgical tools are source of metal particles and possible joint damage, published in the Journal of Arthroscopy and Related Surgery during the month of September. Conclusion, the methods, standard surgical tools to 16 bone blocks immersed in saline solution. 8 specimens underwent 4 minutes of exposure to 4 mm of full radius shaver rotating forward at 6,000 RPM. In the remaining specimen, 4 holes were created with a 3 mm drill through a sleeve. The conclusion, this study shows that the metallic micro debris liberated by common arthroscopic instruments at scale much smaller than anticipated. Findings suggested that the metallic microparticles could induce intra-articular damage through a synovial-mediated cytokine response if their concentration reaches significantly higher level. Now coming to the implants, first is the interference screw. It is defined as the interference is defined as the amount by which the diameter of the screw exceeds the gap between the graft and the tunnel. The factors influencing the interference screw fixation is the length. More the length, more the hold of the screw, size and geometry of the screw, torque of screw insertion, and screw material. The screw material is mainly of 3 bio screws, in which there is biodegradable and biocomposite. Biodegradable is polyglycolic acid and copolymers of polyglycolic acid, whereas biocomposite combination of polymers and osteoconductive material. The main advantages of the bio screws are no need for implant removal, revision is easier, do not interfere with MRI, whereas the disadvantages is may break during insertion, needs a special screwdriver, tissue reaction can occur, fixation is lost after partial degradation. By 6 weeks, 80% of the loss of strength and 60% loss of stiffness and increased cost. The biodegradable and biocomposite, the main difference is that one is osteoconductive and biodegradable degrades slowly, whereas biocomposite degrades faster rate than the biodegradable. The metallic screws, the advantages are the high initial fixation strength, well tolerated by the body, and it is cheap. Whereas the disadvantage is damage at the bone tendon junction or laceration of the graft, violation of the posterior cortex, intra-articular hardware removal during revision, or distortion of the MRI images. Peak screws. Peak is a chemically inert and insoluble and has modulus of elasticity closer to the human cortical bone and is compatible with the MRI. Peak does not encourage bone ingrowth or on-growth, but can be reinforced with elements such as hydroxyapatite carbon or tricalcium phosphate, which can encourage bony incorporation. Hence, it addresses the issue that are present with titanium screws, such as the graft damage because of the material hardness and interference with the imaging. Second is the endo button. This is the fixed loop suspensory fixation. Femoral tunnel has 2 parts, the insertion and the connection part. The insertion part is drilled to the diameter of the graft which is being used, whereas the connection part is of 4.5 mm diameter. Tight rope. This is an adjustable loop fixation device. Loop length can be reduced after flipping by tightening the rope. The main advantage is this allows full length filling of the graft part in the tunnel. Suture disc. 2-hole conical suture disc washer used for tibial side fixation. It is available with D hole and round hole. The convex surface of the disc The disc washers sit snugly on the tibial tunnel mount. Thank you.
Rahil, expected more implants in detail. There are many more implants like staples, historical transfix. You should be aware of other implants which are available. And the implants also have much more detail. The suspensory devices are fixed loop, adjustable loops. Are you aware of all those?
Sir, endo button, sir. Yes,
Yeah.
sir.
Endo
Yes,
button is the trade name.
Yes, sir. Yes, sir.
Suspensory devices which has adjustable, fixed, and many more newer implants. Probably for implants we could have a separate class. Instruments, you did cover all the major instruments which needs to be used. So one question for all fellows: if which is the most important instrument? Obviously, the scope and the telescope lens and the sheath for doing a scopy. After that, which is the second most important instrument for you to do a arthroscopic surgery? What do you think, Naveen?
Probe, sir.
Probe. Okay. Other fellows, any answers? Which you think is the most important instrument? If you want to do a scopy, so in other way, without that instrument, it's almost impossible for you to do a scopic surgery. Almost impossible. Fellows, please. Santosh.
Sir,
Ravi.
shaver, sir.
Yeah, shaver. Arthroscopic shaver that revolutionized arthroscopy. So without the shaver, you would not be. Can you imagine of any other instrument which could do the job of a shaver? And shaver is something which is innovative, where no other similar implants, instruments are there in other open surgeries. So this is specific that after the shaver only. So without shaver, it is very difficult to proceed. So when you're traveling and all, if your shaver doesn't work, no point going ahead with surgery. So you have to during time out. So that's why that's very important to check the shaver if it's working or not. So that's one tip which I would give. Apart from that, I think much to add, but we can have another talk on implants if possible, all shoulder and knee together when implants about shoulder. Sir, your point, sir.
No, it's a good point about shaver. Shaver was invented or manufactured in the garage of Lanny Johnson's to start with. He's a surgeon, and before that also surgery was being done. Even synovectomy, everything was done. And I didn't have a shaver for a long time. I had a lot of pick up and use a pickup and pick it up little by little and wash it out. And it never like using a shaver. It's true, absolutely true that you have to use you have to have the shaver, but I hope there is going to be another talk on the blades and things like that. Even today, the implants and all that were not very well covered. Maybe it should be covered again. Thank you.
Sir, we need to have a detailed discussion about the RF ablation also.
Yeah.
That's not been discussed properly, because that is the most important instrument as far as shoulder is concerned. It's as equivalently important compared to a shaver. So we can have a separate session on these things.
Chetan, please note and discuss with you.
Yes, sir.
Thank you, Praveen.
Thank you, sir.
So now I request. Now for me is there. Yeah. Now for me was a traveling fellow from Japan who was the winner of the Asian Cartilage Society Congress paper presentation, which is a traveling fellowship, which is 3 weeks, 1 week in Ahmedabad, 1 week with us in Coimbatore, 1 week in Chennai. So he's in the second week. Welcome now for me, sir.
Can I hear me?
Yeah,
Can you hear me?
your
Okay.
slides are seen now for me. You're audible.
Okay.
You can go ahead.
Okay. Okay. So, nice to meet you. So today, I want to talk about the correlation between ultrasonographic Patellar-Tendon-trochlear globe distance (USPT-TG) and conventional CT-based knee lateralization measures. There's no disclosures. At first, please introduce myself and my hospital shortly. I'm Naofumi Hashiguchi. I came from Hiroshima University Hospital in Japan as a traveling fellow of ICS. I'm working with President Mitsuo Ochi, who is president of Hiroshima University, and Professor Nobuo Adachi, and studying about knee joint. Additionally, I belong to Johns Hopkins Bloomberg School of Public Health, Japanese online program, to get a license of Master of Public Health. 1989, I was born in Kagoshima, where it is located at south of Japan. After graduation at Hiroshima University, I rotated some hospitals, and I have been a graduate student of Hiroshima University Hospital since 2021. So this is a map of Japan. So this is Tokyo. And do you know where Hiroshima is? The answer is here. Hiroshima was hit by an American atomic bomb in 1945 in World War II. The building in these photos is said to be the atomic bomb dome, the only surviving building from the bombing. The atomic bomb was a terrible thing that left us with unbearable after effects, but now we have overcome it and have beautiful trees and rivers, as you can see in these pictures. And as shown here, the G7 summit was held in Hiroshima in May of this year, bringing together not only the 7 major economics, but also the other major nations, including Prime Minister Modi of India. Our orthopedics of Hiroshima University Hospital has 8 groups: hand, shoulder, spine, hip, knee, ankle, oncology, and trauma. That including over 35 doctors. They have professional skills and help each other. And so we always welcome foreign countries' doctors and show them the sites of Hiroshima. And we also have parties with family members. So if you want to come, so welcome to Hiroshima. Okay, so let's start my study. How do you evaluate lateralization of any joint? You may answer TTTG or TTPCL by CT or MRI. Conventional techniques, while reliable, but necessitate patient selection due to the associated radiation exposure, hence limiting their application. Thus, I consider that I can substitute the data by using ultrasound device. However, ultrasound cannot evaluate TTTG or TTPCL because it only sees a shallow site. So I hypothesize that ultrasonographic Patellar-Tendon-trochlear globe distance, USPT-TG, a non-invasive and convenient measure, might strongly correlate with traditional indices, offering a potential valuable addition to clinical practice. This cross-sectional study was meticulously conducted from March through May 2023. Our patient cohort comprised 28 individuals, 21 females and 7 male, taken for our hospital's joint replacement or ACL reconstruction procedures. These patients underwent routine preoperative CT imaging. the demographic parameters exhibit considerable variation with an age range of 12 to 87 years and a BMI range of 16.8 to 40.8. The primary objective was to examine the correlation of the USPT-TG with preoperatively measured CT-based indices, namely TTTG, PTTG, and TTPCL. The secondary outcomes were evaluated as a part of sub-analysis. These included the femoral tibial angle, FDA, and Q angle, and KL classification from studying total low limb X-rays, and the patient-reported lesion score and KUS. We relied on Pearson's correlation and Brown-Rathman analysis with a significance level conservatively set as p-value equals 0.05. And USPT-TG was measured as a vertical distance between the patellar tendon center and the trochlear groove's lowest point, where tangents were drawn. These are demographic data, X-rays and patient score comparisons. Almost there was no significant difference, but we found that FDA, all equal minus 0.42, shows a significant difference between two groups. And correlation analysis reveals the following result. And USPT-TG was 8.2 millimeters, range was 4.1 to 15.4. Compared to TTTG, TTTG was 12.25, all equal 0.56. And PTTG was all equal 0.69. USPT-TG so demonstrated a moderate to strong positive correlation with both TTTG and PTTG by CT. Then I proceeded to Brown-Rathman analysis with TTTG and PTTG. They were almost within 95% limit of agreement. So I considered that TTTG and PTTG may be relatively high predictive performance with USPT-TG. Our investigation revealed that the novel ultrasonographic measure, USPT-TG, positively correlates with well-established CT-based indices, TTTG and PTTG. This relationship might be attributed to the anatomical configuration of the knee, where the patellar tendon extends from the patella to tibial tubercle. Thus, if the trochlear groove could be reliably identified via ultrasound, USPT-TG could be an effective surrogate for the traditional TTTG measure in assessing knee joint lateralization. There are only 2 previous studies about PTTG, but all studies show that PTTG may indicate an effective evaluation. So this is conclusion. We assessed the correlation between USPT-TG and TTTG, TTPCL, and PTTG. USPT-TG correlates with TTTG and PTTG by CT, so we might substitute USPT-TG for TTTG. That's all. Thank you.
Thank you, Naomi. Interesting study. Just one question. Ultrasound of the knee is done in flexion or an extension of the knee?
Thank you. So that's a good point. So this image shows that light flexion about 30 degrees. And so the other day I said to you, and so and TTTG also the lateralizations is very affected by the fixation. And so this study is set by depend on the fraction. For example, we previously took the CT, and CT was evaluated by, for example, some people was evaluated by 30 degrees fraction, but some patients was evaluated by the extension, 0 degrees extension. So that's why I before evaluate by ultrasonography, I saw the CT, and I saw the CT and the fraction, what was the fraction the mean is, and if one patient evaluated by 30 degrees fraction by CT, so I will evaluate by ultrasound in 30 degrees. If the patient evaluated in 0 degrees extension by CT, so I will evaluate by the extension. I will evaluate by ultrasound in 0 degrees extension.
Okay.
Yeah. So that is so. Yes, so yes, so it depends on the fraction. Yes, so this is confounding factor. So I evaluated each fractions evaluated.
Okay, thank you. So
it's a good paper. I'm sure if it really works, and people who don't have CT can do it in their own hospital. But my only question is, was it done by the radiologist or by the orthopedic surgeon? No, who did all the ultrasonography for you? You did it yourself or the sonologist?
No, thank you for question. So recently the ultrasound of the field of orthopedics is recently become popular in Japan. So that sonographic or radiologist in Japan has little knowledge of using ultrasound in terms of joint. So now I am studying about the US ultrasound. And so this study was all only me. I evaluated by my own self.
Good, excellent. Thank you.
Yes.
Thank you.
Any other questions from fellows? So if there are no more questions, we'll end the online session and meet in person.
Yeah, okay. Thank you.
Okay.
Thank you, Naomi. Thank you very much.
Thank you.
So we'll meet in 10 minutes.
Okay. See you later.